Okay, so good evening and welcome to the second AOP webinar. We did one last week, so for those of you that joined us last week, welcome back. For those of you that haven't joined us before, welcome. I'm going to do a few little bits of mild housekeeping to begin with. So the first part of this webinar will be with the CET content, and we'll try and answer some of the questions we didn't get to last time. And then the second bit will be a live Q&A. For the CET part, if you're logged in through the join link that they've received on their via email, via tablet or phone, including the web app, those are all absolutely fine for logging the CET. It's just if you've just dialed in using just the dial-in number, then we can't log your attendance because it doesn't show who you are or anything, so you can't get the CET that way. But for all other methods, absolutely fine. And a couple of people asking already about GOC number. We will we asked for those to be pre-submitted, so those are already captured. If you look at the bottom of the screen, you'll see there's a Q&A function, and the questions will come up. You're all muted. I can't hear any of you, unfortunately, mainly to make it manageable, but I can see the questions coming up, and people are trying to log those and sort of remove duplicates and things for me. Anything that we get that isn't answered tonight, we will try and address via either updating FAQs or putting out some more guidance like we already have. So for those of you that don't know, I'm Peter Hampson. I'm Clinical Director of the AOP, and basically anything clinical that goes on, I'm largely involved in, from clinical negligence through to policy and guidance and all sorts of things. And currently lots of work on COVID as well. The last webinar we had over 400 questions submitted, so obviously we can't get to absolutely everything. It's just it's physically not possible. We are going to try and answer a number of them from the last time, though, in an informative way, so that will make certain that you get interactive CT, which is really important, especially as it's quite difficult to get out and get interactive CT otherwise. So because of that, we are going to just briefly touch on the learning objectives that we're going to cover. So we've got 3 learning objectives that have been submitted for this: ensuring that records are maintained appropriately when doing sort of remote consultations, and making sure the clinical environment is appropriate and safe, and that services delivered for emergencies also meet the essential needs of the patient. So we're going to make certain we cover those, and some of the content will be tailored to make certain that we do so. The main topics we're going to cover are obviously related to the others. What is essential and what is emergency care? How do you provide remote care in these difficult times? We're going to talk about PPE a little. I may not have all the answers that you want, but we'll definitely talk about it. And claiming for GOS and how some of the furlough relationships work. And I've got a special guest, Liz Stevenson, who's our head of employment, who will answer some of the furlough questions that we've got as well. So I'll bring Liz in a little bit later on, and then we'll do the live Q&A bit, as I've said. So first of all, what is essential and what is emergency care? So I think one of the big questions we've seen is, what does staying open for essential and emergency care mean? And I think the most important first point is that these are 2 separate things, and it's important that we don't mix them together, we don't conflate them. Essential care, this is a brief bit taken from the NHS letter, is currently delivered under general ophthalmic services and may include patients who've broken or lost their glasses or contact lenses and need a replacement pair to function. Urgent care is where you've got a contract with the CCG probably at the moment to deliver urgent clinical advice or intervention, so much more along the MECS sort of route, although not necessarily exactly. So broadly speaking, essential is GOS related, urgent or emergency is MECS or similar. Obviously there's always some overlap, and we know that is difficult to separate in normal times. There will probably be a little bit of overlap, maybe quite a bit of overlap. But generally that's how we're splitting them down. And what's important is that you can stay open for essential even if you don't provide the urgent or emergency portion. You don't have to be open for both. It's not essential and urgent or emergency. You can just be open for essential. And then we saw a lot of questions saying, what do you mean by staying open? Have you got to be open as normal? I've told the NHS that I've changed my opening hours. And in our opinion, you should maintain your normal GOS contracted hours, but you might deliver those remotely with face-to-face contact by exception. and only when you've got a problem that you can't solve another way. If you've told the NHS team that you have reduced your hours and you haven't submitted a formal contract variation, then you should just tell them that you're open as normal. If you varied your contract, which I don't think many people will have done, but if you have gone through a formal contract variation, I think it would be advisable probably to revert that back so that the funding that you get is the average of what you were previously providing. So if you're open 9 till 5 normally for GOS, and I think it's important at this point actually to say that for many, GOS hours and opening hours will be the same, but for some they won't be, and this relates to your GOS hours. So if when you registered for your contract, you said you only provided GOS Tuesday, Wednesday and Thursday, then you would only have to be open for Tuesday, Wednesday and Thursday. But if you put down all the days that you were normally open, then you would need to be open for those. But you can mix and match between telephone and email. So you might say that you're contactable by phone between 9 and 3, and then that after 3, it will be email, but you'll respond to messages promptly. That will meet the requirements. That's okay. It's important to stress that that is for the GOS contract. MEX requirements will vary. A lot of the MEX schemes are through primary eye care services, so you would speak to them. If you're not, and there are many other providers, you need to check what the requirements are of those schemes to make certain that you're fulfilling the contractual requirements from those. So, how to provide remote care. For this, I'm going to go almost against what I've just said, and I'm going to mix together essential and emergency a little bit, even though they are very separate things. Some of the steps won't necessarily apply to both, but it's easier to talk about them both together to a large extent, rather than trying to do two separate streams. So it's really, really important that you keep good notes. Most of us are fairly good at keeping notes most of the time, but there are still some issues out there. And normally when you see the patient, if something goes wrong, and you end up in front of the GOC or there's a civil claim, when you ask the patient questions directly and say, do you remember when this happened or that happened? It will normally trigger a memory and they'll say, oh yes, I do remember going to the other room to do that other test. Obviously, when you're seeing them remotely, you won't have any of that. So it's important that the notes really reflect what's gone on. Somebody asked last week about recording the telephone calls. I said last week, don't record the telephone calls. That's very, very complicated. So please don't do that. It's not something to be recommended. And make sure there's some privacy. So try not to have the kids screaming in the background. It is difficult, obviously, for a lot of people. They're working from home. Probably their partners are working from home. The children are there as well. But try and find somewhere quiet, away from the children, if you're going to do a telephone or a video consult. It might not actually affect your ability to do your job, but it might affect the perception of the person that you're speaking to. So they may perceive that you're not doing your job as well, because they may think you're distracted, even if you don't feel you are. So that's important. It's also important to try and have helpful numbers to hand. So if you need to call the hospital or you need to call another practice, it's far easier if they are in front of you before you make that call, so that you haven't got to say, I'll get back to you, or I need to chase that, or whatever. You can just say, okay, I've got the number here, or whatever, and you can make that call or direct them where they need to be directed. If you've got remote access to practice records, make use of it. I've seen a number of the practice management suppliers who have been enabling sort of remote access to records in a different way, which is really, really important. And that just lets you sort of have more information to hand when you're speaking to the patient. The more information you've got, the better it is when you're doing any consultation. Obviously, it won't always be perfect, but if you can have access to the previous records, it's definitely a benefit. And also try and use a pre-prepared record card so that it adds structure and helps you to understand and flow through the questions as you're going. And largely, you can think about the flow a little like this. We're going to hopefully send out, I think it'll probably be Tuesday, a bundle of documents from this webinar with a few things. But this is roughly the sort of flow of how to think about what you're seeing, who you're seeing, which appointment is appropriate, whether you need to see them face to face. It's not meant to be perfect, but it's just to to try and guide you in sort of the thought process of what you're doing for the patient and whether a face-to-face is needed or not. Broadly, so the first thing to do is establish why the patient needs help. And that might be broken or lost spectacles. It might be they have a particular problem. If they've got a problem, you need to work out if there are any red flag symptoms. And if there are red flag symptoms, you then need to work out whether or not you can help them. If it's a face-to-face appointment for flashes and floaters, then you probably can help them, because you can differentiate between whether it's just a PVD or whether it's a detachment. If they tell you that they've lost all vision in one eye, then actually you're probably not going to be able to resolve that. And seeing them face-to-face may not be the correct step. Actually arranging care with somebody else may well be by far the better way to go about it. If you're going to do that, you need to know where the patient can get that help, though. What's the process? Do you call the hospital? Again, have you got the number to hand? Do you need to call the hospital, speak to whoever's on charge and arrange an appointment? I know in some places that is the protocol they've been using. It might be that if it's urgent and you can't see them in a sensible time frame, that you might need to call another practice, whether it's a colleague who you know can see them that day or can see them urgently, or redirect them. So again, having those numbers to hand really, really helps just to make that a safer way of doing things. If you haven't got red flag symptoms, then can you just reassure the patient? Can you offer them advice and guidance via the phone so that, again, you don't have to see them? If they've broken their spectacles, can you just arrange a replacement from a recent prescription? It might be you don't have a copy of that, but it might be they can provide you with a copy of it via messenger or something appropriate, or post it to you if it's not desperately urgent. Work out whether you actually need to see the patient, as the risk of harm from things such as falls is such that actually it is worth taking the risk of a face-to-face, especially if they can't function without their specs. And if you are going to see them and you have the appropriate PPE, that you're happy to see them, and it's all about being personally happy to see them. If you haven't got the PPE, but if you're personally happy to see them without the PPE, sorry, I should say. So we'll come to PPE, but if you don't have access to the correct PPE, it doesn't mean you can't see them, but nobody should be forcing you to see them. That's very, very important. If you decide on a personal level that you're happy to see them, that's your decision, but it's important that you aren't pressured into doing that. If you don't perform a sight test, but it is GOS related, you need to log that activity, but not necessarily complete GOS forms. And we've got a question on that, so we'll come to that in a second. It's important that any advice you give to the patient is really clearly recorded along with any instructions. So if you've told them that they need to get access to some drops or some medication, or that they need to be sort of doing hot compresses or whatever, then it's important that that's very clear what you've told them. If possible, you should provide them with written guidance as well. And you can send that via email or post. People have been saying, isn't that patient identifiable information? Are you allowed to do that? If you send the patient via normal email a leaflet saying as requested, you're not breaching any data protection or anything like that. That will be absolutely fine. It's not targeting it to a particular patient, and we're most likely talking about things like hot compresses, blepharitis, those sort of things that are very easy to self-care, dry eye, those sort of things. And the AOP has a number of resources to help you with this. So we've got a whole suite of leaflets which you can download. The link's at the bottom there. We will include the link in the email that goes out as well. And you can download those. I think they're accessible to everybody. So even if you're not an AOP member, I think you can get access to those, and you can use them to sort of inform patients and to provide information for them. And we've also been working on a remote consultation form, which I think will be live on the website on Tuesday. So this has been developed in two parts. The first part could, in theory, be completed by an assistant. The questions have been structured in a way that they're in very patient-friendly language. So if you look at them and think that they seem simplistic, they're designed like that. So if you've got an assistant, they can almost ask the question verbatim to the patient and just record what they say. And that may help depending on who's doing the triaging and then whether they're passing it on to an optometrist. Or alternatively, if you are seeing them face to face, it also means that you can break up that contact time, that you're closer to them potentially. so that you haven't got that sort of prolonged time in potentially the slightly riskier zone of sort of within 2 meters. Even with the appropriate PPE, reducing contact time is still a very, very big and very important part of keeping people safe. So the triage form will be on the website, or the consultation form will be on the website, and it will be available, I think, Tuesday, and I think we're going to email it out to people as well. So PPE, and this is both exciting and important for the CET perspective, but it's also a bit confusing. So we're going to try and deal with some of that. So a lot of people have been confused by PPE, and we've seen questions over what are the different types of masks, what do I need to wear, how do I dispose of PPE safely? We haven't quite got the answer on that one yet, but we are very much working on it. So we're going to start with the basics though. So the basics are that hand washing, regardless of PPE, is still the most important thing. All the PPE in the world, if you neglect the hand hygiene, isn't going to really work, because you're going to risk infecting yourself, cross-infecting, and all sorts. So it's important that you practice good hand hygiene. Most of you should be aware of this. I'm sure pretty much all of you are aware of it, in fact. You'll notice we've modified the poster to say 20 seconds, because although this is the one that's from the COVID guidance, it actually still said 15 seconds in it. And obviously 20 seconds is the recommendation for hand hygiene. So turning to what type of face mask you need, there are quite a few different masks out there, from really basic cloth, cotton, gauze masks to medical, surgical, sort of procedural masks. And then there are the N95s, the N99s, the N100s, and so on. FFP2, FFP3, you'll have seen all of these terms banded around, and it gets a bit confusing, I think. So we're going to try and get to the bottom of that a little bit, so people know what they need. And originally, medical masks and cloth masks were designed to prevent the spread of infection from wearers to others. But if they contain a fluid-resistant layer, they also protect the wearer against splashes of biological fluids. They don't technically protect against airborne or sort of aerosolized pathogens, but you shouldn't be encountering those in primary care, because the guidance has been clear now that NCT shouldn't be being done because of the risk. GAT, eye care, those shouldn't generate any sort of risk like that, so you can still do those. Blefex and algae brush, those are not meant to be being done as well, for the same reason that they could generate a sort of an aerosolized environment, and that causes a greater risk and would need a different type of mask. Respirators are designed to protect the wearer from respiratory infections when you're in contact with high risk patients. So if you're working in sort of an environment where that sort of aerosolized tears or sort of lung secretions or anything like that is around, that's when the respirators become very important. They form a seal around the face, and they're defined and regulated by their filtration capacity. They also require a fit test. So when you've seen people shaving beards off and having to have a fit test to make certain that they use them properly, that's applicable to those. But it isn't the same for normal face masks. So this is the guidance that we talked about briefly last week, and this has now been sort of formally adopted and endorsed by everybody, I think now. I don't think there's any real contention over it. We can see that the guidance that's been issued says that you need a fluid-resistant type 2R mask. So that is really different to the FFP2. What's important is it's the surgical mask, it's an FFP2, and there's a poster here that we've got on screen that sort of shows the difference between when you need a surgical face mask and when you need a respirator. And this predates COVID by a long way, but it sort of makes the difference between patient contact in the form that we would do and working in the high-risk environments in the same way. So nothing drastically has changed there. It's just now been extended to optometry as well. And the actual different types of masks, when we look at them, you've got type 1s, type 2s, and type 2Rs. And again, it's the type 2R that you need, because those are the important ones. You can see from the table that they have the greatest filtration. I'm very aware it says bacterial filtration, but these are taken from the British standards, and those are the measures, but it's got the splash resistance in it. So the questions we've been seeing are, do I need a respirator? No, you don't. Not based on the current guidance. You need a surgical splash resistant face mask. Will any old face mask do? No, it won't. It's got to be the type 2R. If it's not got the R on it, then it doesn't denote the fluid resistance and it isn't the appropriate one. So it's very important that you check that. That's type 2 masks are generally for healthcare professionals, but it's the R that in this instance is important. And when getting them, look out that they conform to the correct British standard, which we've got on screen here, and look for that type 2R, and then you know you've got the right type of mask. So if somebody's provided something it's not marked up with the correct standard, I would be wary. If it's not marked as type 2R, again, be wary, because what we don't want is people thinking that they've got a sort of false sense of security from these things. People have also asked, does the college guidance say to only use masks? And they've clarified that actually just today. I think it was this afternoon, but no, it didn't, it doesn't. It recommends following the public health guidance, which says mask, apron, gloves, and potentially eye protection. The potential is quite important because people then say, well, what if I don't have all of the PPE? What if I've got some of it? And the guidance does say that a risk assessment should be done. And I think we, and probably the college, think that aprons and masks are really hard to argue against. Masks are fairly self-explanatory, but aprons, because if you are in close contact to the patient and they're breathing on you, and there's a risk that the virus is spreading and settling on your clothes, without an apron, then the danger is that you then touch your top or your trousers or whatever and contaminate yourself. Whereas with an apron, that can be thrown away and that gets disposed of appropriately, which is really, really important, because then you're not going to infect yourself inadvertently when you thought you were safe. You might, though, decide that you don't need goggles because you've got a large slit lamp shield. And I'm not saying that you shouldn't wear goggles, but it might be that the goggles actually affect your view so much that you decide that the large slit lamp shield gives you that protection. I think that would be a reasonable decision to make, but it is very much a personal decision. And also gloves, because going back to the hand hygiene that we spoke about at the beginning of this section, you've got to wash your hands anyway. And unless you've got open cuts or anything on your hand that you're worried about sort of virus ingress via that route, they aren't necessarily essential, because good hand hygiene is still important. If you've got gloves on and you've handled your Volclens, you've handled your slit lamp, handled any of the equipment, you're still going to have to sterilize that equipment. So whether you've got gloves on or not, the only real difference is at which point you wash your hands. So it doesn't overly change it. So you might decide that actually gloves you can cope without if you can't get them. But if you decide that you want them or you feel you need them, that's also completely okay. It might affect how well you can handle certain pieces of equipment, though. So again, very much a personal decision, but arguably there is a little bit of leeway there. Public Health England, again, we're hoping to make these available for you there. They should be either on the website to download or emailed out. Have provided some really good guides on how to put on and take off PPE. And you think it sounds fairly obvious, but it's important that things are done in the correct order so that we don't cross-infect ourselves. And a short summary is as follows. So if you're putting on PPE, you need to take off any jewelry or anything like that, again, just to make certain that you're not sort of contaminating anything that you're going to be wearing. Make sure you've had a drink. That sounds like a strange bit of advice, but if you're going to be in a mask for potentially an extended amount of time and you're thirsty, and you then need to lift the mask up to have a drink, you're going to breach that barrier. So it's important that you've had a drink or anything beforehand, had some water, so that you're not going to get 20 or 10 minutes into the examination and not feel well because you haven't hydrated properly. So that's really important still. Tying back hair just to make certain it doesn't, again, drape into things and get infected. And then it's perform hand hygiene, put on your apron, put on your face mask. There's a metal strip on the bridge of the proper masks, and you mold that to make certain it fits as well as possible. And then if you're putting eye protection on, put them on and then put your gloves on, last of all. And then going back the other way, it's a case of taking the gloves off, cleaning your hands, removing the apron and eye protection, cleaning your hands, and then removing the face mask and then cleaning your hands again. And that's really important, because again, when we think about the gloves, if we just didn't have removed gloves there, actually we'd have clean hands. And so that's where that discussion over whether or not gloves are absolutely essential comes in, because that step might be sensible or might be possible not to perform if you haven't got gloves. So we're now going to move on to claiming GOS and furlough. And we can see that we've had a lot of questions saying, do I claim for a site test when giving advice over the phone or via video? And the short answer is no, but you need to log any activity. So if you've advised over what to do about a problem somebody's got with specs, you wouldn't submit a GOS1. If you're sort of just giving a patient some general advice, you don't need to be submitting GOS1 for those, but it's important to keep the record of it so that if at any point somebody sort of does raise any questions, you can demonstrate what's been going on. And also it's very important, I think, for the profession, just so that we can demonstrate all the things that we do that aren't necessarily just about site testing. Does the patient need to sign GOS1 forms? This is a little bit mixed, but mainly these are going to be really rare. And if you're seeing them in person, we think currently yes, but you will obviously need to disinfect the pen. You will need to disinfect any clipboards or anything like that. If you've got GOS3s or 4s for patients and you want to post their specs to them, do they need signatures? No, they don't. You can mark those as COVID-19 and just send them off to the patients, and then just submit the form, and that will be absolutely okay. And they will pay them. We had that confirmed. Actually, it was confirmed on a webinar yesterday, just in case anybody heard that. And then we had a couple of questions on furloughing, and in a second I'll hand over on the main furloughing part to my colleague. But so, can you provide essential care and claim the NHS England support while furloughing staff? Yes, you can. You can furlough staff who are not involved in providing essential care. Staff who are involved in providing care, even on a voluntary or part-time basis, cannot be furloughed under the rules of the job retention scheme. So if they're coming in, then and they're doing work, they can't be furloughed. But if they're not, then you can furlough them. Can I provide essential care and claim NHS England support while also claiming self-employed support? Well, in principle, we think you can, but it's important that there's that separation of sort of the lost profit from the private aspect and the NHS support for the GOS aspect. There are going to be very, very few practices that don't have a fairly significant private aspect, and GOS probably won't offset it all. I can see there's a few questions about Scotland actually, and I will address those in a moment because it is slightly different in Scotland. So we'll pick those up under the Q&A. But in England, you can still claim both. But yeah, so we'll move on to that. At this point, I'm going to hand over to my colleague Liz Stevenson, who is Head of Employment at the AOP. I'm just going to move the slide on. Oh, and I should say, just before I do actually, we've updated some guidance for practice owners. Last week we said that we would try and produce a ready reckoner, and we looked at it and it was incredibly complex to do, to actually have the detail that we needed. But what we have done is provide sort of considerations for practice in England about whether they should be open or not. And that's gone live this afternoon. That's on the website. So you can have a look at that, and it just aims to sort of aid your thinking around that. So hopefully Liz is there. Liz, can you hear me?
Yes, I can. Thank you, Peter.
Perfect. I'm going to move on and I'm going to hand over to you for a moment and pop myself on mute.
Thank you. Thank you very much. The first thing to note is that, as I'm sure you're all aware, the guidance is changing all the time. So it's very important to keep checking the furlough guidance on the AOP website, as well as the government websites, because we're receiving updates almost every day on sort of changes to the rules. So one of the first questions is, can I rotate the employees who are furloughed? The answer to that is that you can, but they have to be furloughed and therefore do no work for you whatsoever for blocks of at least 3 weeks. And those weeks must be consecutive weeks. So that may help if you've got a number of staff who want to be furloughed, or a number of staff who want not to be, and you want to swap it around, but they must do no work at all for blocks of 3 weeks. Can employees who are furloughed do training? Yes, they can do training, as long as this doesn't provide services to or generate revenue for the employer. Also, if this is training that the employer is requiring them to do, they need to be paid at least the national minimum wage or the national living wage if they're 25 or over, just for the time that they spend on the training. So look out for that. Can employees who are furloughed do volunteer work? Yes, they can, but it's presumed that this is not for their employer, nor can they do volunteer work that provides services to or generates revenue for any business that's linked to or associated with their employer. So the guidance indicates that they obviously can do volunteer work, and it envisages that that volunteer work is for somebody other than the employer. It's assumed by everybody that any attempt to volunteer for the employer whilst furloughed would be viewed as an attempt to circumvent the rules of the scheme. And HMRC has reserved to itself the right to retrospectively claw back any payments. So as an example, the employer has to keep a written record of the confirmation to the employee that they're furloughed for 5 years, which suggests how long HMRC might keep doing those investigations even after the furlough scheme has closed. Presumably this also means that practices would not be able to enter into some kind of quid pro quo arrangement where their employees volunteer for another practice and vice versa. So look out for that. What about employees who have already been made redundant? So the guidance that was recently updated confirms that as long as they were on the payroll at the 28th of February and the former employer agrees, they can choose to re-employ that person for the purpose of furloughing. The guidance doesn't explicitly state that this can also apply to employees who have resigned, but it's presumed that it does, and that if the employer and employee agrees, they could agree to the employee going back on the payroll. Given that this will need agreement from both sides, it may help to persuade the employer if the employee seeking to be re-employed says that they will agree to defer receipt of wages until after the employer has received the monies from HMRC. So can an employer request that their employer puts them onto furlough? Yes, they can request that, but the employer doesn't have to agree. And it's the employer's decision which employees to place on furlough leave, if indeed they choose to furlough any of them at all. Choosing between employees will be subject to existing employment law, for example, the duty not to discriminate. So, for example, that would include not treating people less favourably because of their age or their race or their sex, for example. So for this reason, it will be important to talk to employees, because you may find that some would prefer to be furloughed, some would prefer not to be furloughed. So people's idea about what constitutes less favourable treatment might vary. Okay, so can a furloughed employee work elsewhere? The update to the guidance on the 4th of April confirms that it is possible to be furloughed from your employer and then actually start a new job or continue another job that you had at the same time. But just obviously restating the previous advice that the employee can't do any work for the employer that's actually furloughed them. If the employee is starting a new job, the fact that they are furloughed from another job should be declared on the starter checklist form. Can those who are on unpaid leave be furloughed? The guidance says not if they went on to unpaid leave before the 28th of February. So it's understood that the aim of this is to avoid the scheme being used for people who wouldn't otherwise have been being paid by the employer. So ordinarily those who went on to unpaid leave before 28th of February will have done so for reasons unconnected to COVID-19. The guidance doesn't specifically deal with employees who started a period of unpaid family leave, but it does confirm that the normal rules for that kind of leave continue to apply. Therefore, hope that a distinction will be drawn in this situation to allow those who return from a period of family leave, which started before the 28th of February, to be furloughed after they return to work. But it remains to be seen. And as I said, the guidance is being changed all the time. So is it possible to be furloughed from more than one job? Yes, it is. And it's been confirmed that the cap of 2,500 applies to each job separately, meaning it's theoretically possible to get the maximum of 2,500 from both employers and therefore a total of 5,000. What sort of payments can be claimed for? You can claim for any regular payments that you're obliged to pay your employees, and that includes wages, past overtime, fees and compulsory commission payments. However, discretionary payments like bonuses and commission should be excluded. It's important to note that this changed on the 4th of April, and prior to this everybody thought it would only include basic pay. So you can claim 80% of the employee's gross pay up to the cap of £2,500 per month, plus the employer national insurance contribution and the minimum auto-enrolment pension contribution on the reduced wage. So we heard yesterday that HMRC have told a committee that the online portal is going to be open on the 20th of April, and they expect the first payments to be made on the 30th of April. They say that their aim is to make the first payments within 4 to 6 working days of the claim. So it remains to be seen, obviously, if it will work that efficiently. The current government guidance sets out what information employers will need to make a claim, and it's also expected that more guidance about how to make that claim will be released in the next week or so. So obviously we'll update that on the AOP website when that comes in. What about holiday and furlough? There's been a huge amount of debate about the interaction between holiday and furlough, because it's not actually mentioned in any of the versions of the official government guidance. However, there has today been a tweet from HMRC customer support indicating that it is possible to take annual leave while furloughed, because people had been concerned that a period of annual leave might break up the 3-week block of furlough leave that's needed to comply with the scheme. So this tweet, although it isn't official guidance yet, but it seems to suggest that a period of holiday during that 3-week block won't be viewed as invalidating the furlough. The tweet also says that that holiday would need to be paid at full pay. So if you've got the employer's agreement to a reduction to 80% of their pay, then if they are taking holiday whilst furloughed, that would need to be topped up by the employer to pay them their usual wages. Those are the questions that I wanted to deal with on furlough. So now I'll hand you back to Peter so we can proceed to the Q&A section of the webinar.
Thank you, Liz. I will probably come back to you because I can see there's a lot of furlough questions coming in as well. So I'm afraid I might need to ask you a few and pop you on the spot a little bit.
Of course.
We'll get to some of those. So let's start taking some of the ones that have come in. So somebody said, what about domiciliary care? Can you see them? Probably not, in all honesty. I think most of them are too vulnerable. There's going to be very, very few people for whom that's going to be suitable. You'd have to be a very strong reason to go in and see them. That doesn't mean you can't provide any care though, because you may be able to make something up and post it to them. You may be able to give advice. You may need to coordinate with other caregivers. So it might be the GP who is going in for something else, and you might need to coordinate with them. So you can still provide advice, but going in to do examinations is going to be difficult just because the risk to patients, especially if they're in a care home. I don't think any care homes are likely to be letting anybody in. Is there a minimum number in order to qualify for GOS payment? I presume you mean, is there a minimum number of that you've done previously? It'll be your average of whatever your GOS was previously. So no, in that regard. If you mean, do you have to do a minimum amount of activity by staying open? No, you just have to be open and available. You don't have to sort of make sure that you're doing 1 site test or 2 site tests or anything like that, or at least nobody has defined that yet or said that, so there's no reason to suspect that's the case. What if you need to close temporarily due to illness? Then really you should say that you're closed because of that if you can't cover it, and then in theory they would stop the payment for the period that you are unavailable, and then as soon as you're fit to go back, you would notify them that you're open again, and the payments would restart. Somebody saying essential can be private as well as GOS. Yes, absolutely, but wouldn't be covered by the NHS payments, obviously. But it would. You can still provide essential care on a private basis, and also are urgent and emergency the same thing? We're largely grouping them together in this case, in that they're things that need seeing quickly, but in normal parlance, absolutely not. Somebody asking about, does the GOS advice relate to England and not Scotland? Generally, yes. I'm sorry, I'm doing it again. I'm being very England centric. I apologise for that. The rules in Scotland are slightly different. And as somebody has pointed out, in Scotland, they've been told they can claim for telephone triage and code it. And as far as I'm aware, that's correct. But no GOS form should be being signed in Scotland. That's also correct. They're not signing any of them, but we've got a slightly different setup in England, but not vastly. Somebody saying, how do we get hold of PPE? Gosh, yeah, that's the incredibly difficult thing. So we were on a call with NHS England this afternoon about that, and basically it hadn't dawned on people until quite recently that optometrists needed PPE, and they realise that now. And I don't mean the people we deal with; I mean people further up. So they now are aware, and it's a high priority item because obviously we don't have access. We're also working on other avenues to access the supply chain from other sources, whether that's private, and seeing whether there's a mechanism to access it that way, whether there's a mechanism to interact with the BDA and people like that to get access via some of their sources. So all of these are in the mix, and it is one of the most urgent things that we are currently working on. If I see a patient without PPE, will my AOP insurance cover me? Yes, it will. Obviously, if you haven't got PPE and you had COVID and you knowingly infected the patient, that would be quite difficult. But if you haven't got it and you choose to see them in good faith, then absolutely that would be absolutely fine. Someone has said that the sinks only have cold water. It would obviously be far better with hot water, but the soap really is the important thing. It's the soap that will remove the virus. So that's not necessarily the end of the world, but you would really want hot water if you could have it. I'm just scrolling down. There's quite a few, not quite as many as last week, but there are still quite a few. Somebody asking, will optometrists be asked to join the COVID-19 front line to help with their efforts? Maybe. It would be on a voluntary basis if that was the case. It's not going to be, people aren't going to be forced to join, but there are overlapping skills. So we're still discussing that and looking at how that might be possible, but it would generally be on a voluntary basis. I don't think there are going to be any paid roles in most aspects, but if people want to volunteer, absolutely. Somebody saying, actually, this might be one for Liz. Can a furloughed director still carry out director duties? Liz, do you want to take that?
Yes, we've recently updated our guidance on the AOP website about this, and the furloughed director can still carry out their statutory duties as a director, but they need to do no more than reasonably necessary to comply with those duties. So they shouldn't be actually working in the practice. We have updated the furlough guidance on that, so check that on the AOP website. But yes, they can still comply with their statutory duties.
I'm going to put you on the spot with one that you might need to think about, Liz, so I apologise in advance. If I started with an employer on the 1st of March 2020, how long do I need to work for my employer before I can be furloughed?
Unfortunately, as it stands, you would not be able to be furloughed because you would need to have been on their payroll on the 28th of February. So obviously there have been some recent changes which were announced over the weekend to allow those who had left a job to ask the old employer to re-employ them as long as they were on payroll at 28th of February. But at least at the moment, and we don't expect it to change, the route would be to go back to the previous employer if there is one, because I understand there are no plans to change it for those who started employment after 28th of February, unfortunately.
So actually, while I've got you, there are quite a few furlough questions.
Yes, I can see those, so shall I try to take some of those?
Feel free, that would be brilliant.
Great, all right. So somebody said, will time off on furlough count as continuous service and therefore impact on the ability to claim redundancy payments? Yes, it will. We understand that general employment rights will continue during furlough. That's everybody's understanding. This is a completely new concept which has only come in with this crisis, but everyone's understanding is that continuity of service will continue, and also that employees will continue to accrue holiday whilst they're furloughed as well. Okay, we've got a question. Can furloughed staff who get employment elsewhere get paid by the new employer? Our understanding is that it is possible to be furloughed from one employment and receive the furloughed payment and then start work with another employer as well. But due to the limitations on the date that you were on payroll, that would have to be payment for doing actual work for the new employer rather than being furloughed by the new employer, assuming you'd started with them after the 28th of February. Somebody said, can you select to furlough the more expensive staff members? I can see that why that would be attractive. One thing you would need to be careful of is discrimination law, because it may well be the case that your more expensive staff members may be older. I mean, they may not be, but sometimes that's the way it works. This sort of older and more experienced staff may be paid more. So you would need to look out for whether or not someone could argue there was an indirect discrimination going on, for example, if you selected to furlough the more expensive ones. If, however, the more expensive ones would prefer to be furloughed, then you probably wouldn't have too much of an issue around that. But you need to think about your objective criteria and to be able to justify the reason for those rules. So having that kind of rule, I would think carefully about that and seek specific advice from the employment team if you needed to. As somebody said, will furloughed staff get the increase in the national minimum wage? Not in respective periods during which they're not working, but as I mentioned, if while furloughed they are doing some training which the employer has required them to do, then they should get the national minimum wage just for the time spent training. So chances are this shouldn't impact too much unless they're doing, you know, a huge amount of training whilst furloughed, and that training is training that the employer requires them to do. Just looking through to see if there are more questions on furlough. We've dealt with the holiday in that it does continue to accrue, and as I said earlier, it's been confirmed just in a tweet today that it can be taken during the period of furlough leave. There's also recently been a change in the law to allow employees to carry over to the next holiday year 4 weeks of holiday per year, to carry it over for 2 years, and that's to enable people to take holiday if they weren't able to take it during the usual holiday year because of the COVID crisis. There's no official guidance on the interaction between the two yet, but we're getting information piecemeal from tweets coming out, and obviously we'll update the guidance as and when we can.
Okay, Brill. Should I take a few more clinical ones, Liz, while you just
Yes.
have a look through some of the list, and then
Yes.
to give you a chance just to read them, because they keep moving as we're trying to read them.
Sure.
Somebody said, is the rebound tonometer, e.g. eye care, safe to use? I think I covered that, but yes, it is, because obviously you're not going to generate any sort of aerosolized particles. Do you have any advice regarding a patient wearing a mask too? That's a good question. I think given how limited the supply of the proper masks are, you wouldn't want to use one for that. And I don't think it's necessary. If you've got the correct mask on, you should be okay. If you've got some of the sort of the very basic masks that we talked about, like the cloth masks and things, and you wanted to get the patient to wear one, I don't think there's anything against it at all, but it's not particularly necessary. If a self-employed locum works during this period, would this affect the HMRC grant? Well, the self-employed grant is to do with loss of profits. So as long as as long as you were still losing profits, if you're doing a little bit of work, then it shouldn't, as long as you still meet all the eligibility criteria. Somebody saying, what would I class as red flag symptoms? So when you talk to the patient, any of the things normally that you would be concerned about, and I think we've got most of them on the form I was talking about, but flashing lights, sudden loss of vision, sort of very painful red eye, any of the things that you might be thinking they've got a detachment, they've got iritis, they've got temporal arteritis as an example as well, or something like that. Those sort of things, the things that are the genuine emergencies, sudden loss of vision in one eye, an extremely painful eye, those things, that would very much be sort of the red flags. That's not an exhaustive list by any means, but just to give you an idea. Somebody saying, if a contractor has 2 practices, can they have both practices open but have eye exams if necessary provided from only one of the 2 practices? Is this allowed? So I think Richard Everett covered this yesterday on the webinar he did for the North bit, and that's it's quite a nuanced question. I think if they're very close together and really the travel time between the 2 is almost the same, then arguably you could deliver most of the examinations at the one practice and agree to only see people by exception at the other practice. I think that would be absolutely okay. If they were 30 miles apart, then I don't think that would be acceptable, because as Richard was saying, the traveling would be problematic. You'd have to have a very good reason for that. Somebody saying, sorry, but FPP3 masks are the only type protective of aerosol transmission. That's correct, but we're not dealing with an environment that has aerosolized transmission, and the public health guidance is for the fluid resistant type 2 masks, so the type 2R masks. Somebody saying that the NHS England webinar said GOS1 can be marked COVID-19. I think that would be acceptable probably, but I think if you can get them signed for how few you're doing, I said it was a slightly grey area, so that's okay. Somebody saying, do all type 2R masks have a metal strip? As far as I'm aware, they all have a moldable nose piece, but I'm not an absolute expert. I've learned a lot about type 2R masks over the last few days, but I couldn't swear that would be definite, but from what I've seen, most of them should be moldable over the nose. Is contract tonometry instilling anaesthetic safe to do and advisable, as is dilation with instilling dilating drops? I think if it's clinically indicated, then yes. I think you need to be asking yourself, where do you think the risk is? So if you're washing your hands and not touching anything after you've put the drops in, and not sort of touching your face or anything like that, there's no risk of transmission there. You're not aerosolizing the tears in any way. So as long as you're not exposed to any risk in that regard and you've got the correct PPE, I think that is fine. Somebody saying, can you submit a GOS3 without doing a site test and submitting a GOS1? Currently, no. We are working on that still. I thought we were going to have a solution to that by now. We haven't, but we've raised it, and we've been looking at ways that we can facilitate that, because there are clearly some instances where the patient can't pay, they need some specs, and we need a mechanism for that. So we flagged it with NHS England, and they've gone away to look at it and will come back to us as soon as possible. I'm hoping that will be next week, but I wouldn't like to sort of promise that. Somebody saying, is the PPE recommendation for now only, or for when we go back to work after lockdown? I think post lockdown, I don't think anybody knows. I think the world will be a different place, and it might be that we have to get used to some form of PPE for some time. Probably not permanently, I wouldn't have thought, but I wouldn't be surprised at all if there's a period of time when there is a need for PPE, even when we're sort of almost back to normal. Somebody saying, can I perform remote MEX as a locum, and if so, how? Well, the MEX contract would be the practice. So if you were contracted to provide services to that practice, and you were their agreed way of doing so, then there's no reason why you couldn't. Somebody saying, I work as a locum, is it my responsibility to get PPE, or is it that of the practice I work at? If it's my responsibility, where do I source it from? I would say the practice really should have it. Liz, I know it's not really your area of expertise, perhaps, but is the requirement to provide the PPE that of the practice, or do you think it's sort of on the locum in this case?
Well, I think if they were an employee, then you would say definitely the responsibility is on the practice. I think where it's a locum, it's a grey area really, because the idea of being self-employed would often involve the idea of somebody providing their own equipment. So I think it would probably depend on the terms of the contract between the locum and the practice, because they're treated as two independent businesses contracting with one another.
I suppose, and I don't want to put words in your mouth here, but I suppose if you were agreeing to go in as a locum, that the sort of contract in that process, it would be reasonable to say I will provide services if there's PPE available. Would that be, if it was in the contract, would that be okay, or is that overstepping?
Potentially, but I think the idea of being self-employed is that there aren't these sort of overarching rules, you know, about what the practice has to do, and it's a matter of agreement between the parties. So it might be relevant to think about how other equipment is dealt with, you know, and whether the locum takes any of their other own equipment, as to how it would work.
Okay. Somebody saying, how should frames be sterilised after patients have tried them on? Well, largely in the same way you would sterilise the rest of the equipment. Obviously, you've got to be slightly careful that what you're using is not going to sort of damage the frame. That's quite difficult. It will depend upon what the frame's made out of. Some of them, as we know, are quite sensitive to certain cleaners and almost dissolve if you use the wrong cleaner. But I think from a sort of general process, what you should be doing is anything the patient's tried on, putting to one side so that they're not, so you know they need to be cleaned, and then wiping them down. I think for all the waste disposal guidance, it says that in a non-healthcare setting, after 72 hours, waste can go in with a normal waste. So I would also think by extension, if you took those frames out of circulation for a period of 72 hours and made certain that nobody was in contact with them before putting them back, and just used your normal sort of cleansing wipes, then that would probably meet the requirement. Somebody saying, will the next COVID lecture be on a different topic and be another CET point, or are they repeat lectures? I don't think we've agreed to do another one yet, but I guess I'd imagine we probably will. And I think we will try and avoid duplicating too much content. We are still getting a lot of the same questions, so there will be a little bit of overlap, I'm afraid. But we will constantly update it, and as new things become available, we will try and add new stuff in. Somebody saying, if I'm wearing gloves, is it acceptable to wash my hands with the gloves on? I'm not quite certain why you would want to. The gloves are single use, so I would use the gloves, and when you don't need to use them, I'd take them off and then wash your hands. I don't think washing your hands with the gloves on and then continuing with the gloves on is good practice. They're single use, so I'd say no. Okay, so somebody saying, I locum full-time and have my own limited company. I read that if you have a limited company, you aren't eligible to claim any other financial help available. So, and I might go to Liz in a second on this as well, and then I'll let Liz take a couple of furlough questions. But the limited company one, if you furloughed yourself, you could claim the wages based on the sort of PAYE element. So there is some help available. If that's quite small and you pay a large dividend to yourself at the end, then there wouldn't necessarily be the same level of financial help. Is that sound about right to you, Liz?
Yeah, that's absolutely right, Peter. So anything that you pay yourself under PAYE, you could furlough yourself for 80% of that wage, provided obviously that you weren't doing any work for your company during that time.
Brilliant. I'm just going to take one other very quick one on PPE, and then I'm going to let you take a couple of furlough ones. So somebody's saying, should we have new PPE every day? If not, how would you advise to clean them between patients to minimize spread? They're all generally single use. So masks you could use, as long as you could leave the mask on, as long as it's not contaminated and not damp, sorry, and that would be fine. But once it becomes damp, it would need to be disposed of. And once you take it off, you'd need to replace it. Cleaning them and sterilizing them is a bit risky. So I wouldn't be doing that. I'm just going to let Liz take a couple of furlough questions, and then we are quickly running out of time again. So Liz, you've got a couple of furlough questions to take, I think.
Yes, somebody's asked, do we pay employee tax and national insurance from the furlough pay? So we'd get slightly less as net pay, and yes, that's correct. So the 80% or the 2,500 cap is on the gross pay, and the guidance states that employees will pay tax and national insurance on that furloughed wage. So yes, you would get less than that. Someone's also asked about bank holidays on furlough. as I said earlier, there isn't clear guidance on the interaction between holiday and furlough yet, but the tweet that came out from an HMRC customer support person suggested that bank holidays would be treated in the same way as holidays, and that therefore what this tweet said about holiday would therefore apply. I think, in fact, that tweet probably came out because they were being inundated with questions from people who were worried about people taking the bank holidays over the Easter weekend. So I think we would expect bank holidays to be dealt with in the same way as holiday, although the rules on that have not yet been published.
Brilliant. Okay, and so I've got a couple of clinical ones, and we're technically a little bit over time, but we'll do an extra couple. So somebody saying, if a trial frame has to be used, is cleaning it with an antibacterial wipe sufficient? So the answer, in short, is no, because you need to make certain that the wipe is going to kill the virus as well. Now, if it's got the correct content and all sorts in it that it will also be effective against viruses, then potentially yes, but an antibacterial wipe by definition is no. Somebody saying, what if I locum as well as run my own practice? Can I claim furlough for both? If they're two employments, I think Liz said that yes you could, as long as you meet the requirements. I think is that correct, Liz?
Yes. Well, I mean, you can be furloughed obviously only from an employment. Yes, and then the fact that the furlough guidance has confirmed you can also have a job elsewhere, I would assume must mean it's also okay to do self-employed work elsewhere. If you're also trying to claim under the self-employed support, then we don't know the full details of that scheme yet, but obviously it would be essential for the profits, to have been affected in order to be able to claim under that self-employed support. So I think it's possible, but it remains to be seen, particularly how the self-employed scheme is going to work.
And I presume if they were a limited company and they were furloughing themselves from that part, though, they could furlough from both jobs in that instance?
Sorry, do you mean if they had their own limited company, but they had another employment elsewhere, or self-employment?
So I meant if they were, I think with the locum question, if they were locuming and they were running through their own limited company for the locuming and running another limited company for the practice, let's say, they could in theory be furloughed for both. Would that be correct?
I believe so, if they were paid under PAYE for both. And I think that's the thing that makes it difficult, because I think often with those structures, the PAYE salary is often a lot lower. And so you'd only be able to be furloughed for both in respect of that salary. So I think, yes, they could. It's probably important to note that whereas the furlough scheme for employment says you can, obviously you can't do any work for that employer, the self-employed scheme doesn't require you not to do any self-employed work. So it seems that that's okay.
Okay. So yeah, in summary, yes, potentially, but yeah. I'm going to take two more, and then I'm just going to wrap up because people probably need to get off, and we'll make the recording and all sorts available afterwards. Somebody saying, will this furloughed salary go to the employer or directly to the employee? I think it's paid to the employer, isn't it, Liz?
Yes, yeah. That's right. It's the employer who has to make the claim. So they submit the details on the online portal. HMRC then pays that to the employer, who then has to pass on completely to the employee the monies that they receive, except that the HMRC can also pay the employer national insurance contributions and the pension contributions. So that would be the only bit that wouldn't go directly from the employer to the employee, but yes, it goes to the employer.
Okay, brilliant. I think that's probably all we've got time for. There are 365 questions in the list. I'm sorry we haven't got to all of them, but we will export them all. We'll have another trawl through them. If people want us to do a sort of more of these sort of things and to provide more information, I'm sure we're pretty happy to do so. It might be we have to do one particularly on one topic alone, and we will look at that. Thank you very much for listening. The slides will be available afterwards, and we will make the recording available on the website as well. Everybody, please try and stay safe, and we'll speak to you soon, I'm sure. Thank you.